basically, of course, a lot has changed in the institution, and I will put that to the power of good planning, and then, of course, the quality of the workforce. Okay, basically, what happened when I came in was that, like there were a lot of challenges, very huge challenges in terms of the quality of care that we give to our patients, in terms of the extent of the care itself. Okay, in terms of the motivation of the workforce. Okay, in terms of the integrity of the system, in terms of how the finances are managed. Okay, and quite a number of all those problems. So the first thing we did was to actually do what I can call a need assessment, an environmental scan of all of the challenges that existed then in the hospital. We're also a very small hospital. Many people didn't know that we in fact existed. We're like sequestrated inside the railway compound. Okay, so we faced quite a number of these challenges, and then we came up with 5 pillars which formed our strategic plan. The first one was to motivate our workers, and train them. Okay, and it's not just training for the sake of training. One of the things we found out was that we just employ people. Apart from what they had learned in school, you don't inculcate in them the culture. You don't inculcate in them what you expect them to do. For instance, if an angry patient comes into the hospital with a relative, okay, most of the health workers really do not know how to handle angry relatives, okay, or even maybe an anxious relative. Or if a patient is lost, okay, how do you approach the family? How do you relate with the family? How do you even, take care of the deceased? Okay, how do you ensure that the patients that are around in the same ward, okay, can, would not become, affected by what has happened, and promptly take prompt actions to ensure that. So these are some of the things that we inculcated in our trainings. Okay, what you can call soft skills. How do you relate with the public? So it was not just training for the sake of training. It wasn't just a nebulous, all-purpose training. They were targeted training. Okay, they were targeted at specific roles and responsibilities that we're going to give to you, and what your role is going to be within the chain. Okay, so we knew that we had to do that. So staff motivation and staff training was one thing, one of the pillars. The second one was the quality of care that we were giving to Nigerians. Okay, and quality transcends so many things. It's not just that you are auditing the system, you are auditing your structure, you are auditing your process, you are auditing your outcome. Okay, we realized that generally the care that were being given to Nigerians was suboptimal. All right, and we thought that we needed to do better. Okay, we also know that the skills were not available, so that was why we approached a Dutch agency called Safe Care, which is an arm of farm access. Okay, and then they came to support us, all right, and tried to do like a quality evaluation of our system. And so they were able to tell us where we were, which at that time was indeed very poor. Okay, and then they developed a quality improvement program for us. We created a department for that. Okay, and then each department, each unit, okay, each shift had a quality champion that ensured that in every single unit of our hospital we kept to the quality improvement program. And that was how we became a Safe Care Level 4 hospital, the first federal public institution that is a Safe Care Level 4. Okay, so that was the second pillar. The third pillar, all right, had to do with the need for us to expand our services. Okay, expand our infrastructure and expand our services. When I came into this company, we were 75 bedded, okay, in the center of Lagos, next to Onigbo. All right, so you understand that that was not okay. And then the infrastructure also had decayed. All right, you had situations where we had multiple fire accidents on the ward at that time because the cables, once they had been laid in the 60s, had never been changed. Okay, and then there were a lot of leakages. Okay, and what simply happened in those days, okay, before we came, was that if there was a fire accident somewhere or there was multiple leakages, that particular ward is abandoned. Okay, and then so the number of beds kept shrinking and shrinking and shrinking. So we knew that there was a need for us to actually, repair, rehabilitate what we have and expand the quality of our service for us to even be able to give good quality service. And I'll give you an example. Okay, you find out that sometimes a patient will come, a child will come with abdominal pain, and the child maybe will be on the ward for maybe 2 or 3 days before the symptoms become clearer, and they then find out that, okay, what this child has is appendicitis. At that time, we had no pediatric surgeon. So what they simply would do is to refer the patient after that patient had stayed 2 or 3 days. You don't run in the ward. You don't run an hospital that way, okay? If that had happened, what ordinarily should happen is that you then send the patient to the appropriate department within the same hospital. Not that you now socially dislocate the patient and the relatives again to maybe another hospital 5, 10 kilometers, maybe 20 kilometers away. So we had to take that also as one of our key pillars, okay, the need for us to expand our services, rehabilitate our infrastructure, expand our infrastructure. And that is what, expand our infrastructure. And that is why we were able to move from a 75 bedded hospital to 450 bedded hospital today. That was also part of the reason why we introduced a lot of specialized care, cardiothoracic surgery, orthopedic surgery, neurosurgery, gastroenterology, and all of that, okay, into the system. Pinhole surgeries, which we now do on routine basis here, okay, and then brought in a CSSD, a central sterilization unit, which has become like a training center for the entire country, okay, because at the core of every hospital is proper sterilization, okay. And then, of course, the cancer center that we're building, and then we have to expand our accident and emergency. At that time, we had only 3 theater suites, okay, but today we have 12 functional theater suites, okay. At that time, we had a specialist clinic made up of only 6 rooms. Today, we have specialist clinic made up of 36 different consulting rooms, okay, consulting every day of the week, all right. So the services expanded, okay. Our dialysis, at that time, we had only 1 functional dialysis machine, okay. Today, we have almost 20, 30 dialysis, functional dialysis machine. At that time, we had a non-functional, 1 single-bedded ICU. But today, we're a 16-bedded ICU hospital. So we generally expanded, and there was a need, okay. Then the other thing was for us to ensure that we blocked all the financial leakages, which is what I can call financial re-engineering, okay, because if you are, if you want to expand, then you need to ensure that there is no leakage, or there are no leakages in the system. And it was pretty common at that time, okay. People had their own receipts, and so it was not unusual for a patient to come and pay for services, at that time, and is issued a certificate, the receipt with the patient probably may read 80,000 naira. The counterfoil that the audit will use to track the money may read 8,000 naira. And we knew that in order to be able to beat all of these things, there was a need for us to, deploy technology, which then formed the 5th pillar of our plan, okay, which is the use of technology to enhance patient care, okay. So we deployed technology in our clinical operations and became totally paperless in our clinical operations, so that when a patient comes into our hospital, okay, you don't need any card. You are given what looks like an ATM card that contains both your clinical and financial information. That is what you use to access care from Ibadan. You can actually credit your wallet. Every patient has his own wallet, okay. And so relatives from abroad can actually credit the wallet of their parents in Nigeria accessing hospital. When you see the doctor, nobody gives you prescription sheet. The prescription is done on the system, on the electronic medical record. If you needed to go to the laboratory, the same thing, the laboratory request is sent electronically, the same thing with radiological request. And when the results are coming back, they're also coming back electronically. So we completely eliminated the concept of paper and pencil administration. It created efficiency, a lot of efficiency indeed, because some of the initial crises that we had, okay, were patients, some of them who will come to the hospital. A lot of people come at 8 a.m. By 11 a.m. or 12 noon in the afternoon, the patient had not been seen, and you go to the patient, why have you not been seen? Says they are looking for my case note. Then you go to the medical records, where is this patient's case note? And then they take you to this, what they call their library, where you have maybe almost about 400, 300,000 case notes, and you see somebody who has been laboring there since morning to actually identify. And you say, okay, open another case note, which they call a temporary case note, is open. And then the patient comes again 2 weeks later, both the original case note and the temporary case note are lost. Okay, so with the EMR, we totally eliminated that. Okay, and so, and then of course deployed the technology in virtually everything that we do. I'll take you to some of those things today. And so those were the plans that we were able to bring forth, okay, with our workers. And then when they saw the sincerity of what we were doing, okay, and that's why I keep saying that Nigerians are not difficult to lead, okay. When the workers saw and they are civil servants, when they saw the sincerity, you know, and the results that were coming from those things that we were doing, they bought into the vision, and it became a shared vision. And everybody pulled in the same direction. And of course, the result is what we see today. And that is why till tomorrow I say that everything we have achieved in this hospital actually belongs to the workers. Yeah, I very strongly believe so, okay? And the major reason why I said that is that the workers who are here, okay, the vision has become a shared vision. Okay, the legacy that we're leaving behind has become a shared legacy, okay? And in the last couple of weeks, I've seen a lot of the workers, you know, come up to me and tell me that, look, they will ensure at all costs that this hospital does not go back to Egypt, okay? And also, if you look at a lot of the things we have done, it has become institutionalized. And so it's going to take a huge effort to be able to uproot that system. I will give you examples. Look at the EMR I talked of. Okay, this is an hospital for the past 7 years, in fact, 7 years, 7.5 years, where we have not done pen and pencil administration. All of our patient interactions and patient records are electronics. So it's going to be extremely very difficult for anybody to come today or tomorrow and say that, look, because of some challenges or the other, they're not going to be able to do the electronic system again. Even the workers would protest, okay, because it has made the work a lot easier. We see a lot more patients in this hospital today than we ever saw in the past. Today we register new patients, about 3,000 to 5,000 new patients every month in this hospital. We're able to do that because the processes have been shortened, okay, and the queues, you know, have virtually disappeared, despite the fact that we see very huge volume of patients. So I honestly think that because it's been a case of shared vision and shared legacy, it's going to be very difficult. And you know, when you are leading people, there are 3 options. Okay, the first option is that the workers may actually be resistant. Okay, the other option is that they may comply. You know, compliance. Okay, the MD wants us to do it, and then let us just do it to satisfy him. Okay, the third option is commitment, so that even if the MD is not there, the commitment is already there. And right from the very beginning, we are targeted to get the commitment of the workers. Okay, and fortunately for us, and thanks to God, we were able to get the commitment of the workers. So you find out that many times, even when the supervisors are not there, the workers bend over backward. Okay, and then we also provided guidance. All right, many, you know, one of the challenges in our system is that appropriate guidance are not provided. Okay, so we provided guidance through the standard operating procedures, okay, and the processes, okay, that we created, okay, and so for virtually all our operations in this hospital, okay, we have standard operating procedures that the patient or the doctor or the health workers have actually ingrained, okay, and so when they are reacting or when they are responding to the needs of the patient, okay, they have at the back of their mind the standard operating procedures. So I am quite confident that a lot of the things that we did, okay, would stand the test of time. You know, understandably, when I came, there were a lot of doubts and challenges, okay? And when we started some of our programs, you know, like the automation of the system, the unions understandably were worried. They thought that we were trying to take away the roles and responsibilities of the workers and that it may actually lead to loss of work. Your work can be made a lot easier and the patient also can be a lot happier, okay? So initially there was that doubt and concerns, particularly from the unions. In fact, the first, you know, model of the EMR that we started with, okay, we actually had to ensure, you know, that we created a role for everybody, okay? So that slowed us down. But once the train started moving and they saw the direction the train was moving, they saw the sincerity of the leadership, they saw the outcome. The outcome was pretty obvious, okay? Then everybody, you know, sort of jumped on the bandwagon, and then we started moving at a very fast rate. I'll give you also another example. You know, those days when the patient comes, and then a patient that has been sitting for the past 1 hour, 2 hours, it's not going to be quiet. So there used to be a lot of conflict between the patient and the health workers. You know, the doctor is waiting, he can't see the patient because there is no case note. The case note, the patient is shouting on the medical records that, look, I've been here for the past 2 hours and I have not yet been seen. You know, the medical record who also sees that, look, it's not my fault, it's shouting back at the patient. But, you know, with the onset of AMR, all of this completely eliminated. Then the medical record officer who would stay in the library, you know, for maybe 30, 40 minutes looking for a single case note, now realizes that I don't have to look for any case note again. So his work is a lot easier, okay? And then, of course, once we made a success of that, okay, we then found out that many hospitals, because in this state, we're the first hospital, big public hospital, to adopt electronic medical record, okay? We're the first hospital, big public hospital in the country to become completely paperless in our clinical operation. You know, when you have a small hospital where you see maybe 10, 20 patients, 30 patients in a day, it's the records, the volume of data that you have in that kind of a system is different from a system where you see like 1,000, 2,000 patients every day, 3,000 patients every day. So they are two completely different things. And then the workers started saying that they could do this seamlessly, okay? Then they became happier and they bought into the vision. So for me, okay, looking at it from the context of the entire of the country, okay, I think leadership really matters, okay? Sincere, genuine leadership matters, okay? And good planning is also critical because it doesn't take much for the followership to lose confidence, okay, when results are not coming out. So it has the leadership in conjunction and in collaboration and in cooperation with the followership must have a good plan, okay? Now, once you have a good plan and people can see results, it then becomes easier for people to trust you, okay? They trust your judgment, they trust your leadership, and I can tell you that many times, many of them can actually follow you to war blindfolded. Okay, well, thank you very much. I'm going to base my answer on what research says, okay? There has been quite a number of research on this topic, particularly from the United States. Okay, and the result of those research shows that hospitals that are managed by medical doctors actually perform better, okay, and they are more renowned than hospitals that are managed by non-medical doctors. But having said that, I also think that it is not just a medical doctor for the sake of a medical doctor. It must be a medical doctor who has administrative, okay, and some degree of financial background, okay. So it is that kind of a doctor that, in my own opinion, should manage an hospital. You don't just pluck a doctor from the clinic and say, come and manage. That doctor must have some degree of administrative training, some degree of administrative experience, degree of financial training, and financial experience. Now, hospitals that are managed by medical doctors with those, you know, those qualifications and experience, okay, research has shown that they perform better than hospitals managed by others. And it's obvious, okay? The hospital is a specialized service, okay? The blind cannot lead the blind. So you must know the system, you must know the process. If a doctor says to you, I need anesthetic gas, okay, you must know the importance. You know that I need anesthetic gas or I need oxygen. It's not something that can wait till tomorrow. It's an emergency, okay? So it becomes obvious why it's better for, okay? So that's my own opinion about that subject. So there's no doubt about that. And I think even within the profession, there's a consensus on that, okay? But, you know, you must not look at the health sector in isolation, okay? Which sector is actually working in our country? That's the question we should ask ourselves, okay? Is the educational sector working optimally? Is the transport sector working optimally? Is the public information management sector working optimally? Okay. Is the civil service working optimally? All right. So we will not be doing justice to the process if we look at it from the perspective of only, okay. So definitely there are other systemic factors, to be fair, that is actually dragging back all of the sectors in our country. The major sectors that are working well in our country are manned by the private sector. If you look at the communication sector, okay, you can reasonably say that it's doing very well, but it's private sector led, okay. If you look at the other sectors, the banking sectors, okay, the financial sectors, the fintech sectors, okay, all of those sectors that are doing well are manned, okay, they are private sector led. But if you look at the systems that are not doing well, okay, you find out that they are the public sector. Don't forget that when the GSM license was granted to MTN and the then Econet, okay, it was also granted to Nitel. Do you have the Nitel GSM system today? No. But do you have the MTN? Yes, it has grown and is even said to be one of the most profitable within the MTN group. So I'm not sure the problem really is the it's not so much of, I think it's the problem is systemic. Okay, it's a public sector systemic problem, and that is what, in my own opinion, we have to address. Good question. What we did when we came in was that initially we had a 4 years plan, and then when that 4 year plan was coming to an end, we then developed another 4 year plan. Okay. And in the 4 year plan, we already made up our minds that, look, it's going to be, we'll have annual plans, and then we'll have monthly plans. And at the end of every year, like you know, we would go for a retreat, okay, review what we had done the previous year, identify what we did well, identify what we did not do well, identify what we need to do better, okay, and what we did not complete. Include it in the following years, okay, and then ensure that we remain focused, all right. And we also needed to be strategic, okay. Now, it's not, the typical day-to-day administration of an hospital, okay, may not lead to growth. Okay, it will just ensure that the system functions. It is the planned, the strategic plans, okay, that will lead to growth. So while you are doing the day-to-day hospital administration, somebody wants to go on leave, somebody needs to replace the bed sheet, somebody needs to, buy whatever, okay, all right. You also need to look at the strategic component of it and see how you can ensure that the hospital grows. Okay. And you need to strike a balance. I think what we have been able to do is to strike that balance, to keep our eyes on the strategic, development and growth of the hospital, at the same time to keep our eyes on the day-to-day running of the hospital. If you do one at the expense of the other, then there will be challenges and there will be problems. So it was the human capacity development. Okay, human capacity development, because our biggest strength remains our workers. Okay, and our biggest weakness also remains our workers. It's sometimes a bit difficult to reorientate. Somebody is 56 years of age, and for almost the 30 years or 32 years that he has been in the service, he has been doing paper and pencil administration. And then you come and you start exposing her to training on the use of computer, and he sees that he's going to retire in another 2 to 3 years, and it doesn't really see the need for him to learn a new skill. Okay. And then somebody is used to printing his own receipt. He goes home every month with maybe 2 million or 3 million, and suddenly you are saying, look, you have to conform yourself to your salary, which is maybe about 200,000 or 150,000, and you have taken away what I can call the feeding bottles. Okay, you would expect some degree of resistance. So the most difficult, of course, was or rather, is the human resources element. The second one, okay, is the need. If you look at most of the pillars, you find out that if you are going to become technologically a technologically driven hospital in a system where it had not happened before, one of the key things you need is power. So we have to take on the power challenge. On an average day in this hospital, maybe we'll get 3-4 hours of power. Sometimes, and you can quote me, in 2 weeks, 2 continuous weeks, we don't have 1 minute of public power. Okay. And it's not infrequent. It's not something that happens maybe once a year. Okay. Sometimes 3 days, 4 days, the public power will not come at all. So we've had to depend and plan our strategy around, alternative to the public power, like the generator. We consume 80,000 liters of diesel every month. And if you, take into consideration the fact that we have to pay tax on our own diesel, we have to give room for contractor profit on our diesel, then you find out that we're buying 1 liter of diesel at about 1,500 per liter times 80,000. That's what we consume in a month. And then NEPA gives us a bill of between 15 to 20 million for the the public power. Give us a bill of between 15 to 20 million for the 3 to 4 hours that they give us. And sometimes for the 2 weeks that we don't even have power. So it's a challenge, but we embrace the challenge, okay? And you'll find out, and you can also call the workers and find out that in the last 7.5 years, we have been able to deliver 24 hours power, because without it, we can't function. We're completely automated. Okay. And for me, our biggest achievement, okay, is that we have been able to positively influence the healthcare space. On an average month, we find about 4, 5, 3 hospitals, public hospitals, private hospitals, military hospitals, a whole state government. Okay, we have had visits from entire state healthcare system, the commissioner, the permanent secretaries, all their CMDs, the members of the state House of Assembly, everybody coming here to study our system. So if you look at in terms of the number of hospitals we have mentored almost 40, 50 hospitals, okay? And our electronic medical record had been adopted by almost 45 hospitals all over the country, okay? So our CSSD, we train maybe about 4 or 5 hospitals every year, okay? We have a number of hospitals, military hospitals, tertiary hospitals, who send their staff to our ICU, okay, to be trained, to our neonatal intensive care units to be trained, to our EMR to be trained. So for me, our the biggest achievement of the hospital has been that we have become like a training ground, okay, to many other hospitals. We had mentored so many other hospitals, and it has, in a way, okay, positively influenced the healthcare ecosystem. It has had a lot of ripple effect, just like, okay, whichever, I mean, in terms of training, like I said, okay, we are training nurses for the military now, okay, we are training doctors for some of their doctors have come in for training. The CSSD, okay, we have trained from our central sterilization unit, we have trained so many hospitals, okay. So when people are looking for best practices, they come to our hospital. The Lagos Business School, they run a program that is called the HMP, okay. Now, part of the HMP is a practical element, which is a whole day's affair, okay. And they bring their students here, all right. For the whole day, they go through our system, you know, in order to use our system to demonstrate best practices, okay. The University of Lagos also runs an infection control diploma program, okay, which is led by Professor Ogunsola, who is the Vice Chancellor of the University of Lagos. For the past 5 years, okay, they use our hospital as, you know, the reference center of what, you know, a good infections control program should be. So these are the ripple effects that it has had. The Lagos Business School recently did a case study on our hospital, and that case study was published, okay, and it has gone, it's being used all over sub-Saharan Africa. Recently, I met a professor from one of the African countries. You know, I was sitting beside him in a plane, and what he was reading was that case note beside me, okay, you know. So I allowed him to finish reading it, and then I told him that, look, this is my hospital. I didn't tell him that the case note is about me. I told him that this case note is out. And he asked me a number of questions and even offered that he wouldn't mind to sponsor me to come and, you know, be part of one of the case study sessions. Okay, so that is the kind of impact we've had within the system, both within the state and also nationally. First, you know, one of the interesting things really was that I still have a friend who ran one of the best known hospitals, private hospitals in this town. And he called me one day and said that when they were planning their strategy for the new year, okay, and they actually listed out their competitors, all right, the only public hospital that was listed as one of their competitors is the Federal Medical Center, Ebute Metta, okay. And like I said, it's all due to the efforts of the workers, okay. Now, you know that motivation, we make a lot of mistakes and think that motivation has to do with only money, okay. Yes, money is very important, and we try as much as possible to do that, okay. Now, what do? We ensure that they get their salaries on time, okay. What government has approved for them, okay. When they run into trouble, their kids are sick, you know, they are sick, you know, with, you know, severe, sometimes, I mean, we're all human beings, sometimes some may have things like heart disease, cancer disease. We don't abandon them. We, you know, in a confidential way, come to their aid to support them. When their kids want to do internship, when they want to do, you know, housemanship and all the rest of them, we make our system available for them to be able to do that. Their work environment, okay, we also make it conducive. Recently, a matron came. I think the son works in one of the big organizations in Victoria Island. And he said to me, came with the son, that I've been telling this, my son, to visit me at work for the past 3 months. Now he has come. And the reason why I wanted him to visit me at work is because I visited him in a space of work. And I realized that his office, his environment where he works, is not any better than my own office on the ward. Okay. And so when he visited me, he was surprised that I also have my own office as a senior matron with air conditioners, with good table, with everything that I need. And so that's why I brought him to come and see you. Okay. So these are the kind of things that you find. So sometimes it's not just the money alone. Okay. Then we provide them with the tools, all right, that they need to do the work. We make the environment conducive for the work. I will also give you one example. 8 years ago when we came, okay, you know, some of our floors are 3, 4 floors, okay? When you are moving a patient from the ground floor 8 years ago to the top floor in those days, okay, sometimes those patients are physically carried through the stairs, patients who can't walk because the lifts were not functioning. All right, but today we have 5 lifts that are fully functional. So nobody needs to carry any patient again. And so we continue to explore, you know, and use technology to ensure that their job becomes efficient. I'll give you another example. Okay, we found out that 20% of our attendants do is to carry blood from one ward to the main lab. Okay, go and collect drug from the pharmacy to the ward, you know, going up and down. All right. So recently we introduced a pneumatic system, which I will take you to before you go. With that pneumatic system, okay, if a patient needs, what do you call it? A patient needs a drug, all they have to do is to contact the pharmacy. The pharmacy, using that pneumatic system, will send the drug directly to the ward. Or a patient, you know, you have taken blood samples from a patient here, all right, you don't need to run to the lab to go and drop. You just drop the blood in the pneumatic system. The pneumatic system automatically takes the blood to the laboratory. So making the job easier. Communication also, okay, is what we have our own regulated communication. So you want to talk to somebody in 3 or 4 or 5 or 6 wards away. Previously, you send an attendant, go and tell them in so and so ward to come and carry their patient. But these are the things that we have made a lot easier. So these are factors that actually play into motivating the workers, quite apart from the bread and butter concept, you know. In the initial phase, okay, it was more of opposition because of fear of the unknown. This man who is talking of technology, this man who is talking of who is blocking, okay, has he come to take our job? But soon enough, okay, once the results started coming out and they realized, then it became overwhelmingly positive. And it has remained overwhelmingly positive since then. Yeah, thank you. You know, I was at a program in a business school in 2007 in France. All right. And we had people from about 45 countries that attended that program. It was Earth Leadership Program then, okay, in Fontainebleau. All right. And one of the things we discussed had to do with earth, you know, the resilience of the different healthcare systems. And at the end of that discussion, what became clear is that the countries that had, you know, resilient and functional, effective healthcare system were also the same country that had good health insurance system. And so, to be honest, okay, it's difficult if we don't work on our health insurance system. There is nobody in this country or in any country that keeps money away for the day he's going to be sick. All right, except the super rich, they don't even keep it away. The only thing is that they can always draw on it. Okay, so and healthcare all over the world is not cheap, and so that is why it's good to pool resources so that those who are well will contribute to the care of those who are ill. I will give you an example. Even the salaries alone of healthcare workers, which is why it's an international, I mean, healthcare professions are international professions, where that's why people pick them all from all over the world. Okay. If you look at the area of orthopedics alone, which is my own area of specialty, okay, in orthopedics, there are about 8 different specialties. Okay, which means that if you're going to run an effective orthopedics unit, you must have 8 different orthopedic surgeons. Okay, and you must be able to pay them. The only way you can pay them is from, okay, in a system that is not a social system where people don't depend on government. It has to come from the money you are making. And so these are, and then the consumables, okay, healthcare consumables, majority of them are imported. Right? So care, the cost of care, and the concept of cheap healthcare, in my own opinion, does not exist. Healthcare is never cheap. Okay. Now, what then do we need to do? What we need to do is to find a way of paying, despite the fact that it's not cheap, and that is where the concept of universal health coverage comes. Okay, and I think that is what we should drive at. Okay, we need to ensure that as many people in our country, as many of our countrymen as possible, are put on health insurance. And the more people you put, the more risk every people share. Okay, and so the less impact it would have on a single individual who has fallen ill. Okay, and that is one of the biggest challenges we face in this present system. Every month, I can tell you that we waive almost about 5-6 million naira for patients who cannot pay. Today alone, I have waived 1 million. Okay, for a patient whose relative had stayed almost, I think maybe almost a month, okay, in the ICU. Okay, and they say, look, we can't just afford it. We have seen instances when people, you know, we are very close to Onibo. People will just put somebody in the Onibo boys, will just put a patient inside the wheelbarrow. They will wheel him to the front of our hospital, bring him to the accident emergency, dump him there, and disappear. Wow. So we're not going to allow that patient to die. Okay, we have seen an instance where a youth copper, we didn't even know it's a youth copper, had an Okada accident, had a brain injury. We didn't know anything about him. We had to operate him. We had to do brain surgery for him without paying a dime. Okay. We have seen situations where a herdsman was beaten by a wild animal in the bush. Okay, and he just managed to get to our hospital. From the overwhelming sepsis, became unconscious and remained with us here. Nobody knew, okay, for maybe almost 30 days before he became conscious. All right. So those are the kind of things that we face. But where there is health insurance, it covers all this, including the vulnerable group. And so what we must drive at is to get good data, get good planning, okay, find a way of bringing the informal sector. The challenge we have now is how do we bring the informal sector into the health insurance scheme. The formal sector is well covered. The government workers, the company workers, okay, but the market women, the Okada driver, the motor vehicle drivers, the taxi drivers, okay, they are the people, the farmers, okay, they are the people in the informal sector, and they form the majority of our country, and they are not in the healthcare system. And Because they're also not in the healthcare system, it creates inefficiencies in the system. I will give you one example. I have a CT scan there, 128 slide CT scan. Okay, and we do this machine can do up to 80, 90, maybe 100 investigations a day. Okay, but on the average day, we do about 10. Why? It's not that there are not patients, okay, that can make us do 100. It's just simply that they cannot afford it. There's a gap. So the more we do, the cheaper it becomes. All right. So maybe the CT scan that is being done for 50,000, when 10 persons are doing it, if we get 100 people, okay, it may become 10,000 or 20,000, which is what happens in India, which is why, okay, the cost of investigations in places like India is very cheap because the volume is there. We also have the volume, but the capacity to pay is not there. And that is where the health insurance needs to come in so that everybody who needs this service can access the service and then can then leverage on volume, okay, and then ultimately the price will go down. So these are some of the things that we need to get right if we're going to get our healthcare system right. I'm not saying I'm leaving public service totally, but I need to recover myself, to be honest. I need to, as a person. The pressure in government job is enormous. You have the national assemblies, you have your bosses, you have the ministry, you have the outsiders, you have the pressure from people, friends, family, people who don't even know you, who believe that you have a solution to all the problems, people who can't even offer services, who just heard that, look, this is a government establishment, they are awarding contracts, those kind of. So the pressure is enormous. And honestly, in my own opinion, if you are not getting any other thing from me too, if you finish, you even if you are going to come back, you need to recover, to be honest. So I need to recover. It's not that I'm saying, no, I don't want again, no. But I need to recover. Because if we don't repair our country, who will repair it for us? And that's what I say to my friends who travel abroad. Are you going to go with your father, with your mother, with your niece, with your cousin, with everybody? So it's in our interest to ensure that our country works. And our country can work, but we need good leadership. People who know that, look, like when you're going into government, you must make up your mind. Is it name you want to look for, honor, like they always say, or money? Okay, and there's a Yoruba proverb that says, if you are going out to look for money and you meet honor on the way, take honor and return home. Because when you get money, it is honor you are going to use it to buy. And at that time, the honor may not be available. So that's just it. So if we can have good leadership in our country, and then we pray for peace and work for peace. Okay? Because it's also said that, look, you must pursue peace because it's always in flight. You must seek it because it's always in hiding. Okay? So if we have good governance and we pursue and seek peace and look for peace, okay, then our country will blossom. We have population, which is one major factor. We have strong, heavy, large youth population also. Okay, so we're lucky in a way. But how does a country improve when there is no power? How? What drives technology all over the world? What drives advancement? Drives the economy? It's power. So how do we improve when we can't sort out our power? We can't sort out our transport. When you leave this place now going to Ibadan, you can't guarantee what time you get to Ibadan. There was a predictability in business, in everything. You must be able to say to somebody, meet me in my office at 4 p.m. Then why must you come with a car of your own? Public transport. Okay, so these are the things we need to look at. Education. All right. When I was growing up, I attended public schools. Okay. I was in Federal Government College, Ilorin, which was a totally public school. At the end of the term, during the term, they will give us provision. So even if you are from a poor home, you didn't need to go to school with provision. At the end of the time when you are going home, they will give you transport allowance to take you back to your wherever you came from. Okay. When I finished my university, year 1, year 2, year 3, year 4, year 5, year 6, medical school, I didn't pay kobo until when I finished, and then they gave me my bill. And what did that bill come to? I think it was 40 naira or 20 naira, I can't remember at that time. And I went back home with my degree. I told my father I've passed though. He brought out the money. I said, no, it's 20 naira. I said I should take everything because he was happy. And when I was in secondary school, I never heard somebody say, I'm going abroad to go and school. Everybody was, because the schools were good, you know. So look at what we have. So we need to work on our country. That's my belief. My biggest achievement, to be honest, is that we were able to positively influence the healthcare space. Okay, we mentored, like I said, over 45, maybe 50 health institutions. Okay, we showed, you know, that this thing is not rocket science. It can be done. And what is just needed is commitment, you know, honest leadership, good planning, okay? And then share the vision with those who are going to work with you. And then they will drive the vision. So for me, honestly, it's not, I think the biggest achievement we have made as an institution is that we have been able to positively influence, to some extent, the healthcare space. Yeah, you know, and honestly, that is also one of the tragedies, with all due respect, of our country, that for decades we continue to import the same thing and we have never really thought about. Okay, but one thing I want to commend this present government for, at least in the Federal Ministry of Health, okay, is that one of the core programs is what they call, you know, the unlocking the value chain, okay, in the health sector. And so this idea of us buying all our drugs from abroad or buying all our consumables from abroad is one of the things that the present leadership of the Federal Ministry of Health is trying to actually, you know, stop. And they have set up an office for that purpose. And that office is generating a lot of, because we're a big country with big population, so it's generating a lot of waves all over the world, okay? And many organizations are actually coming, you know, to say, look, we want to start producing this here, particularly in the pharmaceutical industries, where a lot of efforts is going into us producing our own APIs. Once we're able to produce the APIs, you know, active pharmaceutical ingredients, all right, then we are one step away from producing our own drugs. And it's in the long-term and short-term interest of our health security system for us to be able to produce our own requirement. Like you said, look at what happened during the COVID, okay? When everybody locked up their borders, all right? And then those countries that could not produce, they were left high and dry, okay? So it's a road we must travel, okay? And I think something is being done in that regard. And I only just hope and pray that that process would be accelerated and then we can get to the destination. Even if we're only able to produce 30 to 40% of, there's no country that is an island. So even if all we're able to produce is 30% of our requirements in the health sector, I can tell you that we'll be home and dry. And then we're able to produce that 30% and be able to export the same part of that 30% to neighboring countries so that it can bring in forex for us. But as it is today, virtually almost everything that is used in the health sector is produced from outside the country. And that is not good enough. Yeah, you see, for me, as a country, what we must target, okay, is for us to have a functional healthcare system where people don't have to pay at the point of need. In the United Kingdom, for instance, the only person who paid for healthcare is the person who cannot wait. Okay. In our neighboring Ghana here, okay, a huge volume of about 10, 15 years ago, we were on 3% together. Only 3% of the healthcare system is covered by the health insurance. Okay. Now, about 10 years or 15 years later, maybe 10 years later, okay, almost about 50% of Ghanaians are covered by the health insurance. Okay. So as long as people have to pay for healthcare from their pocket, I am not sure that we will reach the promised land. So we must first work on, because planning, I believe so strongly in the power of planning. We need to first work on our data. How many are we? What is our age stratification? How many of us are working in the formal sector? How many are working in the informal sector? How many people are vulnerable? Okay, those who are working in the formal sector and those who are working in the informal sector, they need to make contributions to the health pool. The vulnerable, okay, maybe the very poor, okay, the very old. Then we must find a way of paying for their health care, okay? And government can pick the bill, okay? And then pull all of this together, okay? It then create an health economy. And then we then need to structure our healthcare system, okay? What we have presently is completely fragmented. You can take up, once you have your money now, you live in Ibadan, you can go to UCH straight and say you want to see a cardiothoracic surgeon, okay? Healthcare system is based on referral. Your journey must start from your GP in your area. Who has your medical history? It also prevents waste. Waste in terms of resources, waste in terms of manpower. Okay? Somebody has malaria and he has gone to see a physician in the teaching hospital. It's a waste of human resources. Okay? And it's not just taking care of your curative care alone, also your preventive care. Okay? Once you have your GP, and maybe your GP is managing 5,000 lives, okay? It's an holistic management of your healthcare system as an individual, okay? They call you when it is time, for you to check your BP. If they have not seen you in a month and you're supposed to be checking your BP, they will call you to come and check your BP. They will call you to come and do your sugar level. They call you to do your full blood count, regardless of whether you are sick or you are not sick, so that they can pick those things that would happen in 5 years, 10 years from today, and start taking measures to ensure that you don't fall victim of those things. Because if you fall victim of those things, the impact is on the community. It's the community that is taking care of you. You are contributing, but the less the number of people who are, seeking care, okay, curative care from the insurance, the better for the community, okay? We now know that we can predict who would have diabetes in under 10 years. That's what they call the pre-diabetic now, okay? So if somebody does his full fasting blood sugar and the fasting blood sugar is 110, that person is not yet diabetic, but it's pre-diabetic. But can that person take measures, reduce sugar, take to exercise, reduce weight, okay, close monitoring, and prevent that diabetes from happening? Or even if it is going to happen, ensure that in the next 30 years, it does not happen, so that it doesn't become a burden on the healthcare system. That is what we talk of in preventive care. Somebody is hypertensive, okay, and then the GP says, you have to see me, take your BP yourself at home, but once a month, you have to see me, okay? And then that person does not develop stroke throughout his life, because preventive care is good. Because if he develops stroke, it becomes a burden on the healthcare system that will drain the central pulse. I don't know whether you understand. So that is what we must target. It's not rocket science. There are things that can be done, but it involves meticulous planning. It involves political will, okay, and it involves us, having a good idea of really how many are we really, what is our stratification, okay. Because the disease of the old people is not the same disease of the young people, so that way we can have a whole healthcare system, and then of course provide good leadership, which is part of the core um, things that the present leadership in the ministry is also advocating, okay, and then take care of our health security, and then of course ensure that our parameters are good, and then prevent, take measures to prevent this kind of calamities in terms of the figures that come out of our maternal mortality, infant mortality, and all those other things, And then once we do that, I'm convinced that if we start today, okay, by the time we are 10 years, if we start to work today, by the time we are that 10 years down the road, then we'll have a healthcare system that Nigerians can be proud of. It will not be that we have achieved everything, but we would have moved the needle substantially. Yes, the word of advice is that they should stay here, okay, and let us grow the system together. Sometimes the grass is always greener on the other side, but when you look from far, you may think, oh, this is green, but by the time you get to the grass, you find out that, okay, it's not as green as you think, all right? And, all those places we're running to, basically, it's because they developed their system. So let's take the bull by the horn and let us develop our own system. Part of the challenges too is that some of those people look at it and see that there are some factors that are outside their control. For instance, the political leadership factor, it's outside the control of most persons, okay? And so they just look at it and they give up on the system. But giving up on the system will not provide a solution. We must engage the system and ensure that we make our contributions and